Okay, good evening everyone and welcome to the June edit of the BOMSS Journal Clubs. I'm really excited tonight because we've got the excellent team from the bariatric unit in Taunton who are going to present two really interesting and related papers to us, so which will be sure to spark some exciting debate. Before we start, I'd like to thank our sponsors, to Medtronic, for sponsoring tonight's event, and to my co-chair, Mr. Sheriff Howard, who is the education lead on BOMSS Council. Just to note also for those moving forward in terms of our education programme, our next event will be on the 22nd of June, and this is the educational webinar which is hosted by Dr. Manisha Sharma from Homerton Unit, who's clinical biochemist, who's going to talk to us about nutritional deficiencies after bariatric surgery and the management of that in more detail. And those of you who remember her journal club from a few weeks ago will know that there was no shortage of questions and discussions and advice that we can get from her. So without further ado, I'd like to hand you over to Mr. David Mahon and Miss Marianne Holliman, who are consultant bariatric surgeons at the Taunton unit, who will introduce their team and our speakers tonight. Thank you so much.
Thank you very much, Roxana. Hi, I'm Dave Mahon. I'm a bariatric surgeon at Somerset Foundation Trust in Taunton, and one of my colleagues will be joining us later, Miss Holliman. I'm delighted to be asked by BOMSS to host a journal club. I was initially a BOMSS fellow many years ago, back in 2007. How time's flown, and it's great that one of the next generation of fellows is going to be here today presenting a paper. But before that, we're going to hand over to Mike Rickard, who's one of our nurse specialists, who's going to present the first paper. I think we've got 12 minutes for papers, about 6 minutes for questions, and very much encourage you to use the chat function or the question and answer function to ask your questions, and we'll put them to the presenters at the end. So without further ado, I'll hand over to Mike Rickard, who's going to present on the efficacy of bariatric surgery clinic-based pharmacist. Thank you, Mike.
Thank you, David. Hi, I'm just sharing my screen. Right, so without further ado, so I'm Mike Richard. I'm the upper GI clinical nurse specialist for Taunton, and I'm working alongside two bariatric nurses. The paper is about efficacy of bariatric surgery clinical-based pharmacist. The reason why we chose this paper is for relevance to our practice is because I think currently we don't have a pharmacist working alongside our one-stop clinics where we have the pre-operative bariatric meetings. We do follow the guidelines with the medication changes for the first 2 weeks. The current setup is that the medication changes are initiated by the postgrad doctors or by myself using the local NUT guidelines. To ensure that the changes are, if we're unsure that the medication are, that we need to change them, I usually discuss medication with the ward pharmacists, and they're usually pretty good. I do rely on information from the patient or on EMIS if they're local. Unfortunately, because our patients are from all over the Southwest, so therefore EMIS is not always an option. Or I get my information from the bariatric specialist nurses who provide me with the medication lists. The reason why we chose this paper is because we seem to recently have more problems with either the medication reconciliation with our electronic prescribing and or the advice we give to the patient, and they're not really well following them potentially as well. So the setting for this study was it's a single study center. They were looking retrospectively of introducing a clinical pharmacist as a preoperatively set up, and to see if that has an impact on their patient satisfactory, adverse drug reactions, and the length of hospital stay. The setup was that they have, as part of their preoperative clinic evaluation, each patient would see the pharmacist about 30 to 60 minutes, and to evaluate if the patient satisfaction, and they used a 5-point Likert scale from strongly agree to strongly disagree. The clinical pharmacist only provided advice to the prescribers and to the patients. They did not prescribe. And the reason why they also wanted to do the study is because there was limited literature available to describe the role of the pharmacist in a preoperative bariatric setting. They had 135 eligible patients in the end. 76% were female, and they're split in roughly in about 2 groups. The control group was 67 patients, and in the other group were 68. The study population mean age was about 48, and in terms of the surgery, they had about 53% had the Roux-en-Y bypass, and 47% had a sleeve gastrectomy. I mean, I call it the good. What the study shows is that they had a really high patient satisfaction due to the medication clarification. They went into quite a detail with the patient of what they needed to do and what kind of changes needed to be done. And predominantly it was done because they had a medication plan established prior the hospital admission, which gave, I think, the patient a bit more autonomy and a bit more clarification of what is actually expected from them. On the day of discharge or before they were discharged, the medication reconciliation were actually done by the pharmacist, which enabled them a swifter discharge. They were aiming for patients to be discharged in the morning due to their whole hospital setup, and having a pharmacist on board actually helped them to achieve this. Medication problems were quickly identified, some high-risk medication. They were swiftly acted on. For example, they identified oestrogen therapies early to reduce VTE, so they made sure that they didn't take them before the surgery, and gave advice to the ward staff and the patient as well. The bad, it's a small sample size. It's only 135 patients. They introduced the clinical pharmacist in 2018, and therefore 100% of their cohort was actually eligible for their small study. The historical cases were from 2015 to 2017, and they were randomly selected. And I couldn't figure out why they didn't select all of them. Some of them had exclusion criteria because they had other surgeries. But they, from each year, 2015, 2016, and 2017, they recruited about 20 to 23 cases each year, which then had roughly the same amount of the cohort then actually the control group. They had an own definition of high-risk medication. However, they did not really specify it in the study. They pointed a few out: benzodiazepines, insulin, and estrogen therapy, but nothing specific was really said about anything else. There was also no mentioning why they introduced it, if they had any problems, and how their preoperative setup generally is, who's actually involved in their setup. It explains that the pharmacist was actually introduced, and they had this 30 to 60 minute slot, and the recommendations were then sanctioned by the surgeon. But only 89%, so I'm not quite sure why not the whole 100. It's a bit unclear what their setup is and who's actually involved in the whole setup. So in conclusion was then that they had a really high satisfactory. They had a 97% patient satisfaction because it was quite clear what patients had to do. Again, it wasn't really said if they had it wasn't really said how many consultations they had while they were with the patients on in the hospital. That might have contributed to that as well, but that's not really explained. They identified the medication problems quite early. However, I've put this here, why not cut out the middleman and actually have a prescribing pharmacist? Because potentially that can give some other problems as well if you have someone like me in my role. In terms of length of stay in hospital, there was no change actually. In the control group and in the other group, they had they used a standard 2-day stay in hospital, and the length of stay for the control group was 55 hours. They used hours, and in the other group it was 57. So there was no difference. The downside of the study was, like I said, it's a small sample size. However, I do think it gave us the paper gave us food for thought, potentially to introduce a pharmacist into the setup if that is not already as part of your setup, because I think it might smoothen some issues, especially when we have patients with polypharmacy these days. We tend to operate on a few more older patients as well, who have quite a lot of other problems, and therefore they take quite a lot of medication. Yeah, that's my food for thought, really. And I'm not so sure if I had my 12 minutes, but that's it for me. Thank you very much. And any questions?
Thank you, Mike. That was a really interesting presentation, and it's kind of really brings up a lot of questions. I was just trying to think in terms of both the logistics as well as kind of the results that you presented from the paper. While we're just waiting to see if there's any questions from the audience, I wanted to ask you, because I really like the idea that you're suggesting about having a prescribing pharmacist, but obviously in those departments that we don't have that capacity now, is there anything out there in terms of a training or accreditation for, you know, CNS prescribers or junior doctors prescribers in terms of focusing on the weight-related dosing and just having that focus on the altered physiology that our patients have compared to normal BMI?
So as part of my role, I had the non-medical prescriber course I had to attend. And during the course, they don't really talk, it's more generic. So anything which is in BNF, I technically can prescribe. They don't really, part of the course is nothing bariatric. Hence, if I do struggle with any medication, I go to the ward pharmacist. I don't think in Taunton there is a specific bariatric pharmacist, but the ward pharmacists are usually pretty clued up, and they have much more access to information than I have. Especially when it comes down to if need to figure out their regular medication. Because if they live locally to Taunton or in Somerset, I can use EMIS. And I don't have access to the NHS spine, where the pharmacists in our hospital have, and they can give me the information from there, especially with the medication. Apart from that, I do rely either on my judgment, because I'm getting pretty good to it with these days, or I just go to the pharmacist on the ward and get me there. And they do actually the same course as I do, funny enough.
I was really hoping you'd have you had a slide about the good, the bad. I was waiting for the ugly slide.
Yeah, I actually did, but I could. I thought that was too harsh.
It is too harsh. No, it's surprising the design of the study or the way it's been reported, because it was published in Obesity Surgery, which is obviously quite a good journal. So I'm surprised that it got through with these various limitations. So I guess in our unit, we've had a very, very interested pharmacist who's been wanting to become part of the MDT, but funding and time pressures and just the logistics of it is the main hurdle. Do you have in Taunton, have you made sort of inroads? Do you have anything at all comparable to this role of having a dedicated pharmacist attend your MDT, or is that wishful thinking?
I think that's, I'm afraid that's wishful thinking at the moment. We do have, Mike is a nurse prescriber, our two other bariatric nurse specialists and a nurse prescriber, well, one's a nurse prescriber and the other one is doing the prescribing at the moment. So we have nurse prescribers, but not dedicated pharmacists. Interesting. My reading of it there, Mike, is that this is pre-operative, clinic-based for 30 to 60 minutes, so a decent amount of time. They probably get longer with the patient than I do pre-operatively. But if you look at the interventions they made, I think 90% of the interventions are post-operative management. If we were going to institute a pharmacist, do you think that before the operation is the only time to see them, or it would be worthwhile seeing the patient in the in-hospital phase as well?
I think it would be good to either side of it. It's mainly because in our team, I'm the only prescriber apart from the postgrad doctors, and we usually have only one around. So our other patient types tend to be quite sick as well, so we spend a lot of time with them. So actually, if we would have a ward-based pharmacist who is doing the bariatric side of it, that would actually be quite helpful. I think getting it through the business case might be tricky because I think we need to prove something beforehand that it's obviously valuable.
Yeah, and unfortunately, the paper didn't show a shortening in the length of stay. If it did, it might be easy. And of course, pharmacists are in short supply, like many professionals in the NHS.
Yeah.
Good. So we've had a few really helpful comments and suggestions in the chat box. If you haven't seen them, just open them up and have a read of them. Shall we move on to the? Thank you very much, Mike. Shall we move on to the next one?
Okay, the next paper is going to be presented by Andy Curry. He's our Royal College of Surgeons fellow currently, and he's overcome the adversity of a poor winter of operating to hopefully come out on top over the summer. And I'm looking forward to hearing his presentation, looking at the upgrade study on how URSO affects patients after bariatric surgery.
Thanks very much, Marianne. Thanks to BOMSS for getting us involved with this, and hopefully that's sharing now. So my paper from the journal last one we describe is the upgrade study looking at ursodeoxycholic acid double-blind RCT. So as we know, gallstone disease and bariatric surgery heavily linked to weight loss associated with initial phase recovery after bariatric surgery, both associated with the development of gallstones. To such a degree that probably around about a third of patients within 6 months of bariatric surgery will have gallstones identified if you ultrasounded everybody. There is a lot of evidence extending back for quite a long period of time that ursodeoxycholic acid, which is one of the bile salts, is quite effective at reducing gallstone formation, but there has always been a history or concern about tolerance, particularly with related to abdominal pain and diarrhea with taking it. But it's actually quite unknown if giving ursodeoxycholic acid in the perioperative period affects symptomatology when gallstones are already present. So what do the guidelines tell us? Well, the European Association of Study of Obesity makes no mention of whether you should do anything with ursodeoxycholic acid in terms of preventing gallstones, and the EAS guidelines recently published stretch as far as saying you could consider giving ursodeoxycholic acid. So on the background of all that, the excellent team in the Netherlands have developed a multi-centre placebo-controlled double-blind superiority RCT. This was done for 24 months follow-up. Their primary outcome was development of symptomatic gallstones. They defined symptomatic gallstones as either biliary pancreatitis, as defined by the ANTA classification, acute cholecystitis or cholangitis, as defined by the Tokyo guidelines, or biliary colic, as defined by the Rome criteria. So they included anybody who was scheduled for either a sleeve or a Roux-en-Y gastric bypass, who had an intact gallbladder, so i.e. had a gallbladder in situ that hadn't had any intervention previously. They did exclude anybody who was having revisional surgery or obviously had any prior gallbladder surgery, and any condition that might affect the bile salt recycling, so Crohn's disease, ileal resections, or liver disease. So the intervention was they gave ursodeoxycholic acid, 900 milligrams, split in 2 tablets or two doses for 6 months, or placebo, which was shaped to look exactly the same as the trial ursodeoxycholic acid, so no obvious difference. They did plan initial subgroup analysis, and they published this in their trial paper, on their protocol paper a few years before. They wanted to separately analyse Roux-en-Y gastric bypass and sleeve, and also whether there were gallstones present or absent on preoperative ultrasound. They did plan to randomise, to stratify their randomisation by those particular subgroups, and based on the sample size calculation of reduction in symptomatic gallstones by 50%, they estimated they would need nearly 1,000 patients in the trial. As you can see on the right there, trial pathway was essentially a governed eligibility. Everyone had a battery of investigations, including a preoperative ultrasound, and a number of questionnaires conducted both initially and throughout the 24-month follow-up. So this is their consort diagram. They assessed nearly just over 3,000 patients for eligibility, shuttling through. There was a number that didn't meet the inclusion criterion. Of note, 400 that had prior gallbladder surgery, a couple of hundred that had provisional surgery, and there was just over 1,000 that declined to participate, interestingly. You can see they randomised 492 to ursodeoxycholic acid and 493 to placebo. And as is the way with most Dutch trials, they had absolutely excellent follow-up. Most people completing the trial pathway, very few withdrawals of consent, very few lost to follow-up. So the baseline characteristics, so just saying, are the ursodeoxycholic acid and the placebo group, were they the same at baseline? Well, they had a quite young comparatively group of patients, the usual split of about 1/5 of males and the rest being female. Interestingly, body mass index at baseline was low compared to what we would see in NHS bariatric practice at just over 40 BMI, the usual mix of comorbidities that you would see. The vast majority of patients underwent a Roux-en-Y gastric bypass. They made a relatively late amendment to include sleeve gastrectomy as an inclusion in the trial criteria. So their initial findings were that at 24 months follow-up, there's quite a significant reduction in symptomatic gallstone disease, and that's which they didn't pick up when they combined the whole group together. So everyone who had gallstones and didn't have gallstones, whilst there looks like there's a reduction of down from about 10% down to 6.5% with symptomatic gallstone disease, when they shuttled it through the statistics, it didn't quite meet the criteria for statistical significance. But interestingly, on their secondary endpoint, which is whether the patient had a cholecystectomy or not, there was a substantial reduction in the number of patients needing a cholecystectomy, all comers if they had ursodeoxycholic acid. So when they split out the patients according to whether they had gallstones or not at baseline, you can see quite a significant reduction in symptomatic gallstone disease for those patients who had an ultrasound before they had any of the trial interventions, when it showed there was no gallstones. So nearly 50%, well, greater than 50% reduction in the risk of symptomatic gallstone disease in that group. When they looked at the asymptomatic gallstone group, so they had an ultrasound that showed they had gallstones before undergoing bariatric surgery or having other trial interventions, you can see there wasn't quite such a significant difference. In fact, and as you would probably expect, a lot of those patients underwent cholecystectomy overall. And that's borne out in the secondary endpoint data looking at cholecystectomy. If I just take you back to the graphs, the top ones looking at symptomatic disease, and the lower graphs looking at cholecystectomy. So you can see most of the development of interventions occurs sort of 9 months onwards, as you'd expect, sort of coinciding with that peak episode of weight loss. So ursodeoxycholic acid was not associated with a higher risk of adverse events, so abdominal pain and diarrhea were fairly similar, according to either whether patients had the ursodeoxycholic acid or had a placebo. They follow up all trial adverse events, as you do, and obviously abdominal pain and internal hernias were very common. They're fairly common things that we see in the post-operative period of follow-up of Roux-en-Y gastric bypass. And around 2/3 of patients were able to, in both arms, so either the ursodeoxycholic acid or the placebo arm, were able to tolerate the medication intervention. So their discussion, their conclusions was that ursodeoxycholic acid overall, so all comers, does not reduce symptomatic gallstone disease after bariatric surgery. In a subset of patients without gallstones prior to Roux-en-Y gastric bypass, it reduced quite significantly symptomatic gallstone disease and cholecystectomy. And they hold their hands up and say they've got insufficient evidence for sleeve gastrectomy. So our view on it, well, it's a recently published paper in a high impact publication. It's a collaborative authorship. They prospectively registered the trial and published the protocol, which is all excellent. Multi-center study, very clear inclusion and exclusion criteria, randomization methods, and appropriate statistics. They did describe their intervention in a lot of detail. And then the fact that included patients who had gallstones was also relatively pragmatic in terms of an approach. They maybe could have adapted their trial protocol a bit earlier to include sleeve gastrectomy, and obviously one anastomosis is one of our more common interventions, but that's fucking ahead probably. They reported their study group very accurately. The consort diagram was full, included all appropriate deviations. They didn't talk about the sort of quite considerable number of patients who didn't want to be included in the study. That's quite unusual in Holland. You usually can guarantee being operated in a large centre if you agree to be part of a trial. So the fact that a lot of patients didn't choose to be part of the trial was quite an interesting factor to reflect on. And it was a very balanced discussion. They sat their findings with other published work and obviously limitations and discussion visibility. So what do I think this could mean for practice in the NHS? I would say it's going to create quite considerable impact. It's a low risk intervention. From a medical perspective, I guess, you're offering ursodeoxycholic acid and it reduces the risk of symptomatic biliary disease and the need for further surgery. They calculated the number of needing to treat for symptomatic gallstones as 17. So for every 17 patients with a Roux-en-Y gastric bypass or a normal gallbladder, they would prevent one cholecystectomy, or they know they prevent one symptomatic gallstones. Interesting, the numbers for cholecystectomy don't quite add up in the same way, but if you give it to 26 or 25 patients, you will be able to prevent one patient needing gallbladder surgery. So if you stretch that up to say, what's the average UK bariatric unit, if there is such a thing, about 150 to 200 cases per annum, pre-COVID, obviously, or post-COVID, hopefully, and around half of those being a Roux-en-Y gastric bypass. Bear in mind how practice is normally split currently in the UK. You might avoid 3 cholecystectomies per year, so that's a whole list. And I don't know what practice is like elsewhere, but most patients who've had previous bariatric surgery develop symptomatic biliary disease. They end up on a waiting list of a bariatric and upper GI team as opposed to general and upper GI surgery. And I guess in the context of elective recovery, can you afford not to do this as a sort of devil's advocate position? If you can reduce the need for elective surgical intervention, is there any way we could not afford to do it? There's several unanswered questions. I guess the most important one being, what's the patient perspective on this? You're asking patients to undergo an ultrasound before their procedure and take an extra medication for 6 months to prevent some of them having biliary disease. And whether that would be something that patients would be prepared to be part of or not needs to be answered. And is there any evidence about giving it in sleeve and one anastomosis? And I would make a contention that the UK is probably the best place to run this sort of large randomised trial, and you can sit it within the MBSR quite comfortably. Thanks very much.
Okay, Andy, we've got a couple of questions in the chat already. One is pointing out, obviously, they're only suggesting giving the urso for around 6 months post-surgery. So is it just delaying the occurrence of gallstones? They've only done follow-up for 2 years, haven't they? So are we just going to have problems later on down the line, just delaying those patients needing a cholecystectomy?
Yeah, I mean, I guess that's a speculation, isn't it? So I would imagine that knowing how the Dutch run their trials, there will be a follow-up paper that's probably going to wing its way into Lancet Gastro in about 2 years' time, giving you the 5-year follow-up on that trial, and they'll give us that information. In the meantime, I guess the counterpoint to that is, do you wait? Do you wait to see 5-year, 10-year data before you choose to make this intervention? It's not high risk. Maybe it is you know, pushing the can down the road for 2 years. Is that a problem? I don't know.
Okay, I mean, and the other comment is really they haven't really addressed the cost analysis here. We're obviously talking about additional ultrasound in these patients plus medication. I don't really have a view on how much it is for a month's worth of urso.
Yeah, I think it's one of these medications that's been around for a very long time. It's generic. I don't think there'll be a huge cost. It certainly wouldn't be the largest ticket number emerging from the bariatric budget, I wouldn't think. So and
it's expensive, Andy. It's expensive. So I advise urso 250 milligrams BD for the first 6 months after all my weight loss surgeries, and that course is about £36 a month. That's the NHS indicative tariff for it when you get the GPs. And I've had a few GPs actually in my practice refuse to prescribe it purely based on cost because it's too expensive.
£36 a month.
36 a month for the 500 milligrams a day. Yeah. So it's actually, even though it's you'd think it's cheap, widely available, and should be made available to a lot of people, there is some opposition to prescribing it.
Yeah. There's opposition from the GPs prescribing lots of things. It's as if the money comes out their own pocket. Interesting that the number of sleeves is very low in the Netherlands. Quite a different proportion to most of the rest of the world these days. I know that they didn't have sleeves right at the start, but only a small number were excluded because they did change fairly early on. The other interesting thing I thought was that the compliance with medication was only about 60%. I don't know if they addressed the differences, you know, which ones got the disease and which ones didn't. Was it the compliant patients or the non-compliant patients? So that would have made it even stronger if they could have done that later on.
But I think the issue, I guess, well, the point about that, the reason it wasn't tolerated was the medication delivery aspect of it. It wasn't an urso side effect problem, so it wasn't like they were experiencing abdominal pain, diarrhea. It was just the nature of the tablet they were being given, because the placebo things, they were experiencing similar levels of compliance. So whether it's a tablet that's too uncomfortable to take or just the nuisance of having to take a daily medication.
And the really interesting thing now is if you looked at cholecystectomies within 2 years in the UK, it'd be hardly any, because that's our waiting list.
Yeah, they're still on the waiting list. Yeah, very true. But interesting that they prescribed urso for patients who are already known to have gallstones, because we don't normally do that. Patients who are already known to have gallstones who have bariatric surgery, at least in our practice, we don't prescribe them urso. They're excluded from it. I looked up in the BNF to see whether it's a formal contraindication, but it doesn't state it as a formal contraindication. Have you got a view on that?
I guess that the reason for doing that was if there was a wholesale reduction in everyone, then you wouldn't need to do an ultrasound. You just give everyone urso. You wouldn't need to know whether they had asymptomatic gallstones or not. But obviously that's not the way it came out, and the subgroup was important. Although more people with asymptomatic gallstones did go on to have their gallbladder out than people who didn't have gallstones before their bariatric surgery.
True. An interesting 20% of their population had asymptomatic gallstones. That's really high. I wouldn't have expected it to be that high. What do you think?
Well, I certainly wouldn't have expected them to pick it up in our pre-operative population. I remember years ago, I used to joke that our radiologists, they're much better now, and the scanners are much better. They used to press the F key, it used to say that the scan was limited by body habitus. So picking up 20% of stones pre-operatively in our bariatric population is good going. Sorry, Marianne.
No, I was just going to say, well, I normally say to women that it's about a 1 in 4 chance that you've got gallstones. So I agree that sometimes the scans might not pick them up, but when you've got a predominantly female population, I would say that's probably representative of the population at large, isn't it?
Do you routinely scan your patients before surgery though? Because it's kind of, especially in terms of planning and bypass, do we know what the within that population, the general prevalence is? I guess that would be something really interesting to see first when using this.
In your practice, Sharif, you don't routinely scan, you just
no
You just give everyone or so?
Yeah, we don't routinely practice. Obviously, they go through the tier 3, they have their one-stop surgical appointment. And if they're, we screen them, just Q&A kind of thing, any symptoms of abdo pain, any abdominal conditions, so on and so forth. The answer is no. And so we just give blanket ursodeoxycholic acid for the 6 months. Lower dose though than in this study. So I do wonder how they came up with the dose of 900, because I remember when I literature searched this, I think the optimal dose was 500, it was 250 BD, so 500 a day. So I don't know where that dose, Andy, what did they say in the paper about that dose of 900?
So I think they were copying previous papers in bariatrics where I think they've used that similar dosing. So there's a couple of other trials in the same sort of area where they've used similar sort of dosing to that.
Okay.
We do run a risk of making the pre-op visit more and more expensive and more difficult. I mean, some people will do an OGD on every patient beforehand. Yeah. Some people, and then we add an ultrasound for everyone. They all get a battery of blood tests. Where do we stop? I guess.
Where do you stop? Yeah. No, absolutely. We have a lot of patients though that do. You know, they are on the Facebook forums, and obviously they're interacting with post-op patients who have gone on to develop gallstones. So often you'll get patients asking you, well, can you just take my gallbladder? And obviously the answer is no, because it's asymptomatic and so on. But in your practice, do you routinely counsel them in the consent process about developing post-op gallstones and possibly needing a cholecystectomy, or do you not even mention it? Or mention it if somebody asks? What do you do?
I only mention it if someone asks. I don't do it as part of my routine consent. I don't know about the others.
I think, well, I mean, what is consent these days? It's not just the signing the paper, is it? It's a continuous process from the first time you see them to operate. And I think that during our education session, we have a sort of a formal education session, a group session, that we do go over it. So it is part of the consent process, but it's not one of the things that we list down on the bit of paper that we sort of sign.
Okay, I've just typed a quick prompt for our audience to see if anybody has any further questions. So Chetan, yeah, so he, similar to a lot of our practice, they don't do pre-op ultrasounds, but they do give 6 months routine ursodeoxycholic acid, yeah, to patients. Do you use urso routinely? I forgot to ask in Taunton, what's your practice?
We don't use it.
Would you use it now after this study, or hasn't changed your opinion on it?
I think we'll go away and talk about it.
Yeah.
Okay.
We'll ask our new clinical pharmacist to tell us what dose to give.
And you'll have to get this past the local prescribing committee or whatever it is that have to negotiate it with the GP budgets. It's a big long process, isn't it? Interesting. I had a very keen GP on a private patient, so I wrote a very detailed post-op post-discharge letter to the GP, my standard letter. So these are the BOMSS guidelines. I follow them. Kindly prescribe these and do these bloods and so on and so forth. And including in the prescriptions, I wrote about ursodeoxycholic acid, and the very astute keen GP looked up the BOMSS guidance and saw that actually BOMSS nutritional guidance don't mention anything about ursodeoxycholic acid, and wrote back to me, took time to write back to challenge my recommending the ursodeoxycholic acid for my patient. So that's the new challenge that I've got to come up with a response to that one.
Did you put in a financial case then for how much it would save by prescribing it when you?
So do you know what, Marianne? I wasn't armed with the upgrade study, but I am now. So thank you very much for sharing this study with us.
I wonder, are there any alternatives? Because in terms of obviously tolerability and the literal size of the tablets tends to be an issue for most patients when we see them in clinic, and like how compliant they are in the long term. I wonder if, like, again, from the pharmacist side, whether they would then be able to offer alternative preparations, or if there are other ones that are kind of cheaper but with similar efficacy.
I don't think there's a great deal out there. She'll know more than me. But another question for you all: anybody who has gallstones and has abdominal pain, it's 2 + 2 = 4, and that's not necessarily always the case. It's a bit like you do an anti-reflux procedure on someone they get a little bit of tummy pain, and immediately they're back on a PPI.
Yeah.
So do we think that all these people that have developed symptomatic gallstones really have all got symptomatic gallstones, or have some of them just got a little bit of abdominal pain and then they've had their gallbladder whipped out?
Yeah, fair comment. Fair comment. I think it's probably the latter. So hopefully they'll have been through that process of being assessed by an upper GI surgeon and, you know, taking a good history and trying to link it and offer the cholecystectomy if appropriate. If you'll allow me, I'll close for tonight, because we've got about 2 minutes left in the session. So thank you very much, Team Taunton, for 2 fantastic papers, Roxana for chairing, all of you for joining. And just a reminder that the next educational webinar will be literally in 2 weeks' time. So that's Wednesday, the 22nd of June, Manisha Sharma at Homerton, and it should be a really, really fantastic session. Thank you all very much.
Thank you very much, everyone.
Thank you.
Good night.
Good night.